Hi, everybody, and thank you for your attention. Thank you, Liz, for that amazing presentation that we are just going to build off of here in this next, our time together. We titled this presentation, Eye Movements and Neuroperformance, and a brain-based or a brain-focused assessment of eye movements and oculometrics. And our goal is to help to start to see beyond the physical structure of the two eyes in front of us and see beyond that into neurological inputs and structures that are controlling and inputting and influencing them. My name is Dr. Daniel Demian. I'm a doctor of chiropractic here in Toronto, Canada. I'm also a diplomate of the American Chiropractic Neurology Board. My only disclosure is that I was consultant with Interacoustics, and I was involved in designing and collecting data in their Saccadometry protocol that you just heard about from Liz here. We have three main simple objectives today that we'll only scratch the surface of because this is a in-depth topic, obviously, and the depth matters. But I want to start creating a new paradigm, or start to influence or encourage a new paradigm within our practices. So our first objective is to describe basic brain functions and identify common cognitive screens that are done in urgent care settings, done in primary care settings, and then hopefully going to be done in our own offices. Our second is to interpret saccadometry results in central disorders such as a concussion or mild traumatic brain injury. And our third is to understand the importance of measuring vertical eye movements and the comparison to horizontal, understanding the conditions and pathologies that may have a preference to affect vertical eye movements and the structures underneath those, and incorporating cervical spine assessments into our practice, but also to know when a cervical spine abnormality or error or dysfunction is influencing eye movements or neurological function, specifically here when we talk about balance. So why measure brain function? Well, one of the main reasons is that whether we know it or not, most of us are already measuring its output. When we do an eye movement exam or a balance test, even if that's not what we're calling it. For simplicity, I'll divide brain measurements or brain functions or brain assessment into two main categories. One being structural assessments, and the second being functional assessments or performance assessments. Right when we meet a patient or a person, really when we take in their questions and their intake and their history, we're already starting to triangulate neurologically what's going on. Imaging, which is such an important part of our assessment and our history, and the value of it cannot be understated. I won't belabor the point, only to also say it's a structural assessment that also has limited sensitivity in some factions. And so structural and pathological alterations it's very valuable for, but a lot of functional disorders, we don't get a lot of value from imaging, any type of imaging. And we can also measure the brain electrically. So through EEG or evoked potentials, what we're really measuring is latency and amplitude and velocity and accuracy of a signal's input to its output. Where I spend a lot of my time is measuring performance or function for a few different reasons. One of them is because it's sensitive, can be specific, but also because it matters a lot in the life of the patient. It also matters in the rehabilitative process, which I spend a lot of my time. That's where my work is done, is in the rehabilitation. But the assessment matters a lot towards that. So we can measure function through cognition and memory, or otherwise executive function, which we're going to talk about in detail, sensory motor perception and the loops that go on. I'm going to talk about that a little bit, and also burgeoning areas, autonomic responses, so subconscious responses in the brain, vitals, blood pressure, pulse rate, respiration rate, pupil changes, eyelid changes, ptosis, and sweating changes, among many others that we're looking at. Our brain really uses loops to understand, to perceive the world and to act in the world. And so we usually talk about it as sensory or afferent perception, interpretation based on the environment, the mental set, previous experiences, and then an action. Whether that action is visible or not, oftentimes it's happening. So that could be as minimal or minor as hair raising, pupils changing, sweating, temperature changes, or maybe as major as a movement, an action, or a verbal response, or a thought pattern. There's always an action there's always a reaction to an action, maybe what I would say. And the action is perception, the reaction is our brain's response to that. Important for me in these loops is the feedback and the adjustment that our brain makes. So whenever we do something, our brain assesses that and says, was that appropriate? Was it too much? Was it too little? Was it accurate? What do people think about it? And it makes adjustments, whether it decreases or increases or restructures the response. And this is often done through what we call neuroplasticity, through repetitive stimulations. And so our brain's always assessing in these loops. I love this picture of the brain for a couple of reasons. One is that it outlines a lot of great areas, talks about some of the major functions from them, but also I love these axonal tracks that you can see throughout the brain and the long axons that come and connect these different areas of the brain, showing both redundancy, so our brain's fail-safe systems, but also showing, for me, really, I start to visualize when we talk about concussion or mild traumatic brain injury, is that the shearing of these long axonal tracks from brainstem to cerebellum to the areas of the cortex and beyond. And so that's where my mind starts going, that these areas. But also when we start to look at oculometrics, we want to start thinking about these areas behind it and the pathways and networks behind them and how these areas connect and what they do. So really important for us as we're going through. Our brain modifies. When we talked about that sensory or input, perception and action, then feedback and adjustment. That adjustment comes through two main avenues for us. And so top-down regulations, where we can use cortical processes and regulation of lower brainstem sensory integration centers, and bottom-up bottom-up activation or or assessment in terms of how our input from sensory perceptions and beyond change. And what they do is from top-down regulation and bottom-up activation or input, we change neuronal pools, and that's our brain's main way of adjusting. We change neuronal pools either closer to threshold or an action potential, or farther away, based on what we talked about, what that feedback and adjustment wants to change in the loop, and then we assess it again. So those are our two main ways of adjusting and making adjustments. And when we do our rehabilitation, we're trying to influence those pathways through neuroplasticity. That's really how we use those. The main inputs for eye movements in the central nervous system are integration between the vestibular network, both peripheral and central, the proprioception, which is a very specific word, but somatosensory is a broader topic for it. So perception of the body through fascial connections, the jaw, upper cervical and spinal muscles, through neck muscles, which we'll talk about further, and then visual perception of not just eye movement or dynamics, but also static perception of the world, both binocular fusion of depth and also peripheral vision integrating in gives us a lot of information. Also, again, mental set, which is really important for us, is what's the expectation of that stimulus, and does it match what happens, and what is our emotional state, our arousal state, what's the environment, all those kinds of things are really involved in this and how our brain perceives the world. What can we measure? Well, the answer in this list is many things, and beyond even the things I write here, but many things. And we're starting to tease apart the details of these things, which are so important when we do any eye movement assessment for different conditions and different pathologies. But what I also love in this picture is that these pictures show, for these specific ones, the pathways or the networks underlying saccades, but how detailed they are, how many areas of the brain they involve, and how long and wide they span the breadth and depth of the neuroaxis. And so just to say, with eye movements, the neuronal networks and pathways are well studied underneath. They're also well elucidated, and they are different for different types of movements, or a smooth pursuit versus a saccade, what direction it goes, which we're going to talk about later on, in horizontal versus vertical, but also in each of these different metrics, fixation versus latency versus velocity and accuracy really depend or activate different areas individually more than the others, which is important for us to know as we're starting to elucidate some of the issues that we're seeing and how do we work on them in the different conditions that we deal with every day in the clinic. Those same metrics that we talked about are used as proxies for overall brain function. So latency could be used as a proxy for processing time, and velocity for speed of interaction, and accuracy for accuracy for the accuracy of the perceptual of the world. Decision making can be directional errors. Directional errors can be a proxy for decision making sometimes. And then overall, as they get better or worse as the test goes on, can tell us about fatigability and adaptability, right? Do they get better as the test goes through? Are they learning as adaptability? And then do they get worse, which can tell us about fatigability? That matters to me, right? I won't send a patient home with an exercise that they're just getting continually worse at. Right? I want to find things of where's the window of adaptability and how do we train that? Going along that same viewpoint of using eye movements as a proxy for brain function, this specific video is of a picture with two different images within it, right? And it's kind of showing you both. And so we can use visual perception as a proxy for cognitive flexibility. In this specific test, they're asking the patient, can you see the two images at the same time, right? Can you perceive them in your mind at the same time? Another example of this is this exercise, which I'm going to ask you to try to keep your eyes still and centered on that red dot. What you'll notice is that the background blue ring around it starts to disappear in patches if our eyes are staying still. And what you also notice is when you blink or lose attention is that it will come back, right? And that's an example of how we can use visual fixation as a proxy for attention or visual attention, which is really important again. And so another example of how we use these proxies all the time, we're constantly assessing oculomotor or visual perception as a proxy for other brain assessments because they're well studied. And again, as I said, easy to do in our context comparatively. Brings me into a case study that we're going to do here. This is a high performance athlete that I saw, maybe lower 20s. This patient was, and their whole team came in for some preseason baselines of a lot of a battery different tests of neurological markers. But here what you're seeing is 3 different time points of anti-saccade testing and how I may view this and tease apart some certain things out of that. So we measured these athletes at baseline. You'll see the yellow is pre-injury because obviously this athlete specifically had a concussion, which we're going to talk about. So baseline testing, beginning of the season, is probably done 3 to 4 months prior. Latency is 297 milliseconds, which is within range, not optimal, but within range for what we think for this patient's age and gender. And then the directional error rate is 11%, which is also within normal for this patient's age and gender. But I highlight it because of what we're going to talk about next. So this athlete had an injury, a concussion, and the team was looking, should this athlete come back to play, right? The athletic trainers work in there. I'm seeing them within the week, so let's say 3 to 4 days post this injury. They're looking like, hey, is he good to get back? What's going on? And so what I highlighted in red is his injury statistics. And what's interesting about this case is his latency, which is 375 milliseconds, is significantly higher than what his baseline was at 297, along with the whole battery of tests, again, included within a battery of tests. But this marker is really interesting to look at. So he's significantly slower to respond to visual perception than he had been in the past and make a response. Although, interesting for this patient is that the directional error rate stayed pretty similar, if not actually reduced a few percent from 11 to 7%. This is often what I see in the anti-saccade test, important for me when I'm working with a whole host of conditions, but athletes specifically, because it's easy to understand. I use them as an analogy because they're easy to understand. Is there's often a trade-off between good decisions and speed of decision. So making good decisions fast is a very valuable asset for an athlete. Making bad decisions slowly is kind of the death signal for an athlete, right? High risk of injury, high risk of not being able to play or play well, all those kinds of things. So we were able to work with this patient doing a whole host of vestibular, visual rehabilitation, neck and manual work and retraining of their sensation of where they are in space, and then exertion protocol. And within 2 to 3 weeks, I believe actually this was within 3 weeks after, what we see is we did another assessment, and this patient, along with all their other tests, but this assessment showed that their latency was reduced from 375 to 255 milliseconds to respond in an anti-saccade and make the decision, which is a really good improvement, but also better than their baseline, which is also great to see, and maybe says something about performance training. Not only that, but their directional error rate was 0%. So they are making better decisions faster, is what we can say from that, and a good kind of whole host of the battery improved. And so this is a great outcome for a patient. Also gives us good information to say, even if it wasn't something we worked on with the patient, but saying, hey, I feel a little bit more comfortable about sending this patient back to return to play, which is important because if they are not ready to go back into their world, right, the consequences are high for this person, in that they are playing a sport that obviously the demand is high, but also they are in a direct risk of injury as it's a high contact sport. And so along those same lines, my different models of assessment to looking at someone which aren't concrete, they're really just, I want to give us an idea of lenses that we can look at a person with. And so an example of that is high performance, where you look at your athletes, your high performers, your high executives, and really just look and say, can we maximize performance? And the lens we look at, or the threshold we say for these people, might be a little bit tighter than someone else, right? And maybe a civilian population, or maybe even a pathological population, which we'll talk about. Then I'll talk about dysfunction, which these people may not have structural abnormalities, but they have definite dysfunction, and we become very valuable to them because we can measure the performance and output of these people, which is really important. And there are two conditions that fall within that. It's persistent concussive symptoms is a good example, and also persistent postural perceptual dizziness, PPPD, which maybe there's not hard findings, but we can find functional functions that are below normal for their age and gender. And then there's strict pathology or structural abnormalities, which would be dementia, Parkinson's disease, acoustic neuromas, things that we can see or that are pretty black and white for us. And so it's good for us to kind of separate these three, and there may be many more within them. And there are many more examples within actual structural pathology. So in the assessment spectrum, typically what we're doing is pathology, which is binary, right? It's yes or no, it's black and white. Do you have the condition or do you not have the condition? And there's not a lot of room to say things in between. But the brain is a complex, interconnected system with a lot of redundancies that we talked about. Things aren't always easily described as black and white, yes or no. And so I propose, where I work with a lot of the time, is a functional spectrum. And a function spectrum could be many things, but I'll give you a few examples. Healthy, mildly reduced, moderately reduced, severely reduced, profoundly reduced, or unable to perform, right? And then there could be optimal, average, dysfunctional. And these could be as simple as norms or averages, and then standard deviations away from those. And those could be as simple, and there could be many more, right? And they could be also be condition specific. A lot of healthcare is moving towards that direction. Why? Because a lot of conditions are easiest and most successfully treated at the early stages. But if we're not identifying them, then we will miss them. We miss our window a lot of times of treatment, if it will be treatable at all later on. So I highly encourage it. I'm passionate about that, not only for the high performance population, but also because of that reason, is that's when they're actionable. As a therapist, I love to catch patients in those times. And it doesn't mean I can cure a disease or anything like that, but I can try to give them as much of their life and independence and function back by catching them at these early stages. And you can start to see healthcare and medicine move towards that, talking about things like pre-diabetes or mild cognitive impairment before things like dementia and Alzheimer's, that kind of thing. Okay, so when I talk about this is important to me and a whole host of your collaborative network, interdisciplinary network that work in rehabilitation, but it's important on the assessment side because this is where we start that. So assessment specificity, the more specific we are in our assessment, the better the therapist can work in the rehabilitation or even the communication to the patient about what we're doing with them. So when I used to think about the brain, I used to think in strictly in terms of Brodmann's area or nodes of function. Broca's area would be an example, or Brodmann's area 37, those kinds of things are typical Brodmann's areas. Then Brodmann's areas or areas of the brain started to connect through pathways. We know that, which you saw those in our Saccad diagrams that we saw earlier. And then we really started to think about the brain in terms of networks, which are multiple pathways working together for a function, say verbal function, or say an eye movement, a saccade, or saying attention network, those kinds of things. And that doesn't mean that the areas, Brodmann's areas of the nodes or pathways are false, but we think the brain functions in networks and in frequencies, and those areas or pathways and networks have to be within frequency to function well. Dosage. So when I'm working in rehabilitation, I start understanding dosage based on my testing. So I want to know, does a patient get better or worse as the test goes on? Approximately when do they get better or worse for the reasons I described earlier? I don't want to send a patient home with a exercise that they're just getting continually worse at because of bad information coming into the brain. A lot of times in the rehabilitation, I'm monitoring signs, and I oftentimes, even when I assess a patient, I give the therapist that may also be working with that patient signs of when the system is not going to perform well, because I'm seeing it on my testing. So I say, hey, when their eyelids start to droop because they got a ptosis on the right, or when you see their pupils start to go big, or you can feel for a bit of sweatiness, or when they look a little bit out of attention, those are signs that catch those signs early so we know when to stop and before we really fatigue a patient and lose a therapeutic window. And then rehabilitation, which is, there's two general ways that we look at rehabilitating a patient, and neither are better than the other. They depend on what the patient's issue is. So one is adaptation, which means dysfunctional or areas of poor performance in the brain. Can we start to stimulate or activate them or exercise them so they function better and start to create new neuronal connections and strengthen those pathways through neuroplasticity? Or are we looking for other areas and networks of the brain to compensate because we don't think we can bring that back to life, essentially that area back to a great deal or an appropriate deal of function for us? And so that would be compensation. So now we're going to talk about eye movements and executive function. So standard care in an emergent situation is whether that's within urgent care at the hospital, or a paramedic arrives at the accident, or there's a athletic trainer on the field with an athlete. Typically, they're doing two main things, which is AOO times 3, which is alert, aware, and oriented to person, time, place, and situation. And the secondary version of that would be a Glasgow Coma Scale, which are they having an eye, motor, verbal, pupillary response to different levels of intensity of stimulation. This is incredibly valid. It's also important. I'm not negating that, but I'm also saying when a patient comes to you from those scenarios and they're saying my cognitive testing was normal, oftentimes this is what is being done. And that's good to say you are in terms of life-saving care, what do you need? But not so great to say, how do you perform at a good high level in the world, right? And that's really what we kind of look at. So I want to alert to that. Next, we're going to talk about some certain cognitive tests, common cognitive screens done. And so the first one we talk about is a MoCA test, which is about 15 minutes, and it involves a battery of smaller tests that give us an idea of where they are along the spectrum. And there is some cutoffs of norm and abnorm that we kind of use within that. Then the second is a mini mental state exam, which is a test that is a bit shorter, about 10 minutes. It involves a battery of tests as well, similar in terms of some memory and counting and identifying objects and stating the date and some other common well-known facts. Then there's a mini cog, which is the shortest out of the three, taking about maybe under 3 minutes to complete. And then the gold standard is a neuropsych test battery, which can be anywhere between 2 to 8 hours. Now, the common drawbacks of these cognitive screens, although valuable in their own right, is that The scoring is subjective, and the person matters a lot who is administering the test and the strictness at which they're evaluating it. Conclusions are often based on assumptions. There are statistical limitations, and diagnostic sensitivity of those between conditions is controversial. And as I mentioned before, sometimes they can take a significant time to complete. And context can be important for some of these tests, right? The context of what they understand and what they've been exposed to can be quite important. I'm going to take us into we're going to take us into a case study of a patient with mild cognitive impairment. Now, what we're going to look at this patient is their smooth pursuits to start here. And so on the left, you can see the horizontal smooth pursuits. And on the right, you can see their vertical smooth pursuits. What you'll notice is the waveforms of both are jerky. They are the gain is low, and they're often shooting ahead of a target and falling behind a target. And some of the research points to this for those kinds of conditions is that they often can't predict or hold the visual attention to stay with the target appropriately. And often their gain suffers from that. So we're maybe seeing the evidence of that in the case. And so not only is the gain important, as you can see here, they're falling below their age-matched norms, which makes it easy for us, but also the waveforms of the line and the graphical tracings are also important to me. The next slide you're going to see here is going to be that same patient, but they're doing random saccades, which is otherwise known as a gap or express saccade. And in a gap or express saccade, the target disappears before the new target appears, which usually results in a slightly lower latency, so they're faster to react, maybe less accurate. But you can see with this patient is they are within normal ranges for this test as well. Now, this takes us to prosaccades, which is a test of overlap saccades, which means one target stays there while another target appears and disappears on either side. Now, what the research tells us is that is an increased cognitive or executive function demand, and usually the latency is a bit higher. And what we see with this test is, based on some of the data we're collecting in research, is that it's pointing that this patient's latency is too high for their age and gender. Not only is it too high, it's asymmetrical. So what you can see in the underlined red there is that the left side is 299 milliseconds and the right side is 250. And what that's pointing to is that there's an asymmetrical visual perception, speed, and performance. And even if you look at the graphical representation of latency in the top right of the prosaccades, is most of the red are later and most of the green are earlier, which is kind of confirming what you're thinking, and not a ton of like outliers, right? It's pretty statistically separate. The other thing that we're seeing is that there's a directional error rate of 6%. Now, directional error rate is not a great word to use for this, but what's happening is it's showing that and when we look at the video, is that my patient is jumping ahead of the target, not waiting for a target to appear, but can't hold, it jumps ahead, predicts where it's going. It's a wrong prediction, you have to correct the other way, which is another sign of attentional issues and inhibition errors. Now, the second graph we're going to look at here is anti-saccades. Sorry, let me pop back here. Is anti-saccades. And in this anti-saccade graph, what we can see is that the patient has a high latency, again, outside of what we think norms should be for their age and gender. Now it's asymmetric, where the right side has a 493 millisecond latency compared to the left side, which has 428 millisecond latency. Now, that might be conflicting off just kind of hearing it on a surface level, but actually what's happening is in a prosaccade and the left latency, the left side blinks, they perceive it, they look towards it. In a right side anti-saccade, the left side stimulus shows up, they see it, they choose not to look towards it, and they look to the other direction. So the same stimulus we're seeing is dysfunctional, which is a confirmation for us. The second thing that we're seeing is the directional error rate is 50%, which is a very high directional error rate for their age and gender as well, as we're going to kind of see. All this pointing to what we're mentioning as they're confirming what the diagnosis is. Now, I'm going to give you kind of a viewpoint and a way to mine this. There's two types of directional errors and a directional error correction on one side that we see. The first one we're going to see on the left is short latency or express errors. They're being called in the research, which they're, as the blue arrow is showing, they're usually showing up early in the latency graph. And oftentimes, this is a patient that can't suppress the impulse, looks towards the target in an anti-saccade, and then course corrects and looks the other way. This is what we're seeing in things like concussion or mild traumatic brain injury, some functional dysfunctions that we're seeing. Then on the other side, on the right side, what we're seeing, actually, sorry, I should say that the video in the middle is showing examples of the short latency directional error corrections. On the right side for this patient, what we see is it's including long latency errors, which are much more indicative of neurodegenerative diseases, executive impairments, executive function impairments, cognitive issues, those kinds of things. What's happening is the patient is not just not being able to suppress the impulse to look towards, they're actually totally making the wrong decision and never realizing to correct it, which, as you can imagine, is a reflection of poor executive function. Now we're going to talk about vertical eye movements. And vertical eye movements are less understood, less studied so far, and less elucidated in the research in terms of the neuroanatomical and neurophysiological mechanisms underpinning them, but are important for us to understand nonetheless, or at least start to understand and get a taste of when we're doing our examination and oculometric assessment. Things like a concussion and traumatic brain injury, we know the dysfunction can span the whole neuroaxis. So it's important for us to understand and appraise these areas and not ignore or leave anything behind. The other thing is that other conditions may be specifically targeting these areas. And so it's good for us to be able to at least get some measurements and understand what are the neurological underpinnings as far as that we understand them for a comprehensive neurological and oculometric exam. There are two main areas that underpin, or what we call vertical eye movement integrators, specifically with saccades, the interstitial nucleus of Cajal, and then the rostral interstitial nucleus of the medial longitudinal fasciculus, which are a mouthful to say in their totality for all of us, but are very important in terms of function. As we can see in this diagram of the brainstem, is that they both live at the very top of the brainstem in the mesencephalon or midbrain, as opposed to some of the horizontal eye movement integrators, which are lower in the pons/medulla kind of area. Although, functions don't work in isolation like that, but something that's important. We know that visual stimuli presented in different directions recruit specific brain regions. And when we talk about as I mentioned, horizontal saccades, the paramedian pontine reticular formation in the pons receives saccade initiation signals from the frontal eye fields. And on the other hand, in vertical saccades, it seems like that the RIMLF and the INC tend to receive those signals and produce vertical saccades. The pathway for vertical pursuits more closely resembles the pathway for horizontal pursuits, except it includes the rostral nucleus reticulus tegmenti ponti instead of the dorsolateral pontine nuclei and some of the medial vestibular nucleus that are involved in horizontal pursuits. What they've seen in some concussion and mild traumatic brain injury studies is that vertical eye movements might be more vulnerable to injury than horizontal, and so might be giving us a good idea, and hopefully more people measuring it means we get more information as we're kind of going forward. So vertical versus horizontal eye movements. When we talk about vertical saccades versus horizontal saccades, there's a word called the vertical cost, which means we know that latencies are a bit slower just in the normal population than the horizontal. We also want to know what does the quality look like? And so they notice in vertical saccades, if they don't go straight vertical, and they kind of curve, what you call around the house movement, is that we might start thinking closer to things like asymmetries in terms of like progressive supranuclear palsy or more mesencephalic neostriatal issues. And the behavioral asymmetries between vertical and horizontal saccades have been described in a whole host of conditions that we're going to talk about. And so when we talk about smooth pursuit gain, most of us maybe noticed this if we haven't already, but we do in our normal life do a lot more horizontal movement than we do vertical eye movement. And so a lot of us are more plastic or more trained in the horizontal than the vertical. So decreased gain is expected, a little bit of decreased gain is expected. But if the quality, as you can see in this video, looks like it's zigzagging and jerking all over the place, and we might say that's just not functional for someone. When we talk about an athlete, for sure, but even in our normal populations, civilian populations, and even in our dysfunctional populations, might give us a focus of an area to work with as we go through. And few studies have totally kind of got a full sense of that, especially in concussion, but something that we hope and should be studied further as we're moving forward. controversial in the research and something we want to kind of look at. So we want to understand, is the quality smooth or is it jerky? Is the gain high or low, or is it within normal limits? And what does the quality look like? And also you can see in this patient is that pupillary changes. Is it fatiguing them, and do we see other dysfunction? Head impulse testing of the vertical vestibular canals have also been shown to be lower gain than the horizontal canals. And same with optokinetic nystagmus. There's a decreased gain in the vertical plane than there is in the horizontal plane. And it's good for us to know what should we expect in normal, but also how may that change in certain conditions as we're going through. Speaking of those conditions, we're going to talk about some of them now. And so Parkinson's disease is a progressive bradykinetic disease. And we know a few things are likely or have been shown in the research have been hinted at changing. There's hypometric prosaccades and delayed antisaccades, especially in the vertical plane, some studies have said. And there's an increased number of directional errors during antisaccade have been some of the most consistent findings that they find, specifically in frontostriatal deficits. So talking about those areas of the brain together. Typically, the initial ocular abnormality, or one of the first ones we might see in Parkinson's disease, is hypometria of voluntary saccadic eye movements, more in the vertical again than the horizontal. And so what they're also saying is similar to limb, so arm or leg, limb bradykinesia, slow movements in the Parkinson's population, is that they are seeing the same thing happen in eye movements, specifically vertical eye movements, is that over time they become lower in velocity and lower in amplitude, and something more or something further to be described in that area. One important clinical correlation or correlate of that abnormality of these low amplitude or hypometric saccades is that during visual scanning is that they have a high propensity to lead to falls, especially as you're not aware of your environment in the Parkinson's population, especially when doing turns, which if any of us have worked with that population before, that's something we know well and something well described within the literature. Progressive supranuclear palsy, or PSP, will affect vertical eye movements, and vertical optokinetic is a great indicator of the level of dysfunction. In contrast to Parkinson's disease, the optokinetic nystagmus is induced by downward moving stimuli, or is induced by downward moving stimuli, is reduced compared with optokinetic in upwards moving stimuli, which is important for us to maybe as a little bit of an indicator. And I know when I've worked with patients, sometimes it's not easy to make the distinction between these two different conditions, even for structural pathology exams or neurological consults. Oftentimes it's a diagnosis of exclusion or a symptomatology or symptom cluster that and sign cluster that helps get an idea of it. We know that vertical eye movements are affected in movement disorders like dystonia. Psychiatric disorders are starting to be studied there, everything from major depressive disease to bipolar to schizophrenia. These things are starting to come out, and vertical eye movements may be important and selective for some of these conditions. And then, as we talked about, the changes that happen in normal aging in these populations. Eye movements and the neck, the cervical spine as another way to say that, and the importance of it. So what is our brain's primary question? Where am I and where is that? Evolutionarily, structurally, developmentally, these are important questions for our brain to answer. I often will tell my concussion or traumatic brain injury population that when we're talking about executive functions and higher order functions, they will always be sacrificed by the brain for basics. Sort of the basic, where am I? Where is this in relation to me? And autonomic function. Am I getting good blood flow to my brain as we go through? So really important for us to go through. Our brain is constantly trying to sort through this info and potentially error messages to create an accurate picture of the world around us and where are we in that world. The main players that we talked about before, but in a little bit more detail, is the vestibular system, which really functions in acceleration and yaw, roll and pitch, so rotation and forward rolling or backward rolling, for lateral rolling side to side, and then also pitch, that kind of thing. And then we also get tilt and translation, mainly from our otolithic system, so really important. Somatosensory information, as we talked about, from our muscle spindles, joint receptors, Neck, jaw, and feet are really primary ones that we need to be focused on or need to be aware of. And then the visual system that gives us an idea of where things are in relation to us, and not just dynamic visual oculomotor movement or ocular movement, which is oculomotor function, but also visual perception of binocular fusion and depth and those kinds of things, and peripheral vision as a function of those. So the relationship of these systems that we just spoke about, this is a great image showing how that afferent information gets processed into a motor command that might change what our balance looks like, but much more than that, which comes into things like we can look at the static and dynamic posturography, postural reflexes, and balance markers of those kind of things. Gait kinematics, so how we strike on the foot and how we move and what our swing and phases look like. Muscle tone and risk of injury, right? So where we think we are in space changes our tone of muscle, and that can lead to injury risk or lack thereof if we get it functioning well. The different reflexes, so cervical-ocular reflex or ocular counter-roll reflexes. Cervicogenic dizziness, we know about the integration of the upper neck and some of the muscles around that integrate directly into some of those areas of the brain, but can produce dizziness all by itself. Cervicogenic disruption of smooth pursuits has been shown in the research to be alone by whiplash injuries. Now, it's hard to separate brain injury and whiplash because they often come together, but whiplash injuries by themselves or neck dysfunction has been shown to be able to disrupt smooth pursuits by themselves. And then ocular vergence and neck position is a really burgeoning area of research, is that forward head posture has been closely tied with issues in vergence, ocular vergence, and depth perception in that way. And it also has been tied into sway patterns, especially into the pitch. And that's just being able to be fleshed out more in the research as different subspecialties collaborate on the research, but important things that we may see. This is a great video and a picture above. Wouldn't we all love to have such great reflexes as this owl here or this hawk? I'm not sure actually which it is, but this is a great gaze stabilization in cervical-ocular reflexes where the neck is being stabilized even though the trunk is moving. And honestly, I show my athletes this all the time. If we could aim for something as an athlete in movement, this is fantastic. But something that we also look for and aim for is in our population of balance disabled or balance issues that we're looking to rehabilitate. And some reflexes you can see in the picture above is when the head tilts, the eyes have a response, right? And it's beyond our course here to talk about those responses, but important to know those responses happen. And I'm here to also talk about some of the measurement tools that we'll look at, and then how those responses happen, or we think they happen. So our measurement tools. So posturography, many of you may be using this in clinic, but we can look at sway patterns and where someone is. And these are the tools we can look at to get a sense of the integration of these different areas, which is important. That can be static or dynamic. We can look at walking, so gait kinematics, running kinematics. Pressure sensors are something more widely being used as they're becoming more accessible. We don't need a full mat, but sometimes even just shoes and socks can tell us where they are, or just visual observation of where are they loading and where's the pressure coming. Visual motor, which is really important for us as we're talking about that. So video oculography or video nystagmography, which is the same thing as we're talking about today, and the same tools, just the lens at which you look at it might be slightly different. Video head impulse testing. There's not a video head impulse test that is done with the neck not involved, right? So when we're talking about the inner ear system and we're moving the head, the neck is a huge component of that, and really important to take into assessment when we're looking at it. We might just use visual exams to get the integration centers of where we are and how that changes, and that could be something simple that we're using to understand the totality of what's affecting balance. Structural exam in orthopedics, including palpation, range of motion, and postural analysis. This may not be something that many of you are doing within clinic, but should encourage collaboration across different subspecialties. And this is something I look at within my clinic and get a sense of what that tone looks like. Where does their body get limited in the motion, and also postural analysis, which gives us an idea of where do they think they are in space and not to be ignored. Muscle strengthening, endurance, and then sensory motor tests. And, one specific even for the neck that gives us a good sense of how much does the neck have a part to play in this is cervical joint position air test, which we have some norms to kind of get a sense of saying, is that sensory motor function coming from the neck appropriate? And is it giving good information to the brain? Is it something we can use, or is it actually hampering both visual function and oculomotor function, but also balance as a result of that as well? These are some pictures that I pulled from a couple different studies, which I'll source, but are really important. And these ones show that the neck muscles, or that trigeminal system, represents the connection between the neck and some of the somatic structures, and those derive from neurological structures in the branchial arches. So maybe think vestibular and some of those networks. And that they influence oculomotor muscle function, and by that vein, oculomotor metrics. And the intermedius nucleus of the medulla is a small nucleus in the brainstem, which acts to integrate information from the head and neck and relays it to the NTS, or nucleus tractus solitarius, where a lot of autonomic responses are born out of. And this web led this research group to investigate further anatomical and functional connections between these different areas. And so showing here that muscle spindles within the jaw, the SCM, the temporalis, integrate with some of the vestibular nuclei and influence vertical and torsional movements of the eyes, which usually come together, especially in tilt responses. And some of the research says that they actually supply or give information and may support some of these torsional and vertical responses in there. And we know that the upper neck, C0 and to C2, directly synapse on the cerebellum, and also onto some of the those muscle spindles into some of the areas we talked about earlier, the interstitial nucleus of Cajal and the RIMLF, the rostral interstitial medial nucleus of the medial longitudinal fasciculus, that those become important. And so pain and instability in these areas can create dysfunction within these networks. And it's important to tease apart in what we think may be balance or vestibular issues as well, and often can mimic each other in oculometric assessments. I just wanted to kind of view this and talk about a couple different ways that I might look at postural reflexes. And so these are sway patterns on the force platform. So the sway pattern will matter. Is it elliptical? Will they fall forward into or fall toward a canal plane? Is it rotational? Is it in the sagittal plane, which we may think may be influenced largely by the upper neck and convergence functions of the eyes? Is it in the frontal plane, and we think otolithic issues, or maybe even physical injury to the hip or therefore in the lower extremity? Does the sway pattern change over the test? And in what conditions do they change in? Do they get worse, which maybe indicate fatigability, or do they get better into adaptability? And do they fluctuate? What do divided attentional resources have a part to play in it? And what's their strategy? What strategy do they use? Do they use an ankle, a hip, or a trunk step strategy? How do they go through different degrees of dysfunction that might be given them? And a clinical pearl that I always use is I ask them, where do you feel like you're getting pulled or pushed to when you're balancing? And that may indicate the area of dysfunction, but also how compensated they may be. So if I've had a vestibular issue for a long time and I feel like I'm falling one way, when I do my balance to close my eyes, I already know I'm going to counterweight the other way. And that gives me some important information. I'm going to give another case study, and this will be my last one, so important as a kind of totality of some of just the things that we talked about. So it'll be a little bit more in depth. We evaluated a high-performance athlete who had a concussion neck injury in his sport. He was cleared for return to play by the team, but surgery was being considered for the off-season. This athlete still didn't feel well, so he was sent to us for a more in-depth evaluation and examination. Well, in our physical exam, we noticed that he had a right head tilted forward head posture. Some of the things that we talked about earlier. There's bilateral foot pronation and standing stance, but his sensory motor and reflex testing was generally grossly within normal limits. But when we did a cervical joint position air test, it was outside the normal limits, outside of 6 degrees, which that tests someone has a laser that is pointing straight ahead at a target. They close their eyes, they turn their head, and with their eyes closed, they're trying to find neutral again. And so it gives us a sense of how much does that cervical spinal sensory motor proprioceptive function work in knowing where neutral is for this patient. We did some posturography testing, both static and dynamic. These are just some of my rating scales that we use for our equipment, but maybe a sense of what we do. So this patient was healthy, and then went to moderately reduced when they went to a perturbed surface. So on a normal surface, eyes open, eyes closed, they were within healthy range. As soon as they got to an unstable surface, they started to break down a little bit and fall into the moderately reduced. But we're able to go within their age and gender norms back within healthy with their eyes closed. And so one of the things that we got from this was that they're heavily perturbation dependent. They're relying a lot on what their body's telling them for where they are in space, especially with the vertical line of gravity, which is important. We then did the test in head turns. This patient was able to turn the head in both directions and maintain their balance, but head up and head down were severely out of range. And actually in head up, trying to hold their balance and head up, they actually fell. For an athlete, which is a dynamic sport, you can imagine how important that is when they're head up. And they were falling and don't feel stable, how higher a risk of injury that becomes for them. But if you don't measure, you don't know, and you might assume. This patient would never have told us what the specific issues were. They just know they felt a little bit off, and even that you had to kind of pull out of some of these athletes. So important. Another test we did was eyes holding, balance with eyes holding in cardinal fields of gaze. You can see here is there's issue with the eyes to the right, mildly reduced. Eyes to the left were significantly worse. Eyes up were better, and then eyes down were worse. Now, interesting enough, head up and eyes down are reflexogenically linked, so we might see something, see a pairing, or that may make sense to us in our clinical examination for this patient as we go through. We did our video oculography and oculometric exam. Eyes were normal and healthy within looking straight ahead. When we put this patient in the dark without fixation, they developed a right upbeat nystagmus, although there was a high artifact due to fatigue and low eyelids, but you could see the eyes drifting and jumping. They developed a significantly bigger left pupil as a response to dimly lit light. And then we had the patient hold their eyes in each cardinal fields of gaze. And what we saw is that it was intact. They could do it. But our software, and even by looking at the video, you can see is that they would lose their binocular fusion when looking to the left. They would lose that. And they saw double. They would note it for a second and then refused as they went through, although it was intact. Their their smooth pursuits were smooth and accurate. But the gain was in the normal limits, but they would lose binocular fusion at end ranges in each direction. And if you're not looking at the details, sometimes you'll miss some of these things. In the vertical, they started to break down at the higher speeds as well. Their express saccades or the random saccades were within normal limits. This is a video of that same patient trying to hold their eyes to a direction. What you'll notice is when I mentioned that loss of binocular fusion with their eyes to the left is that they would jump there, they would try to hold. You can see a significant amount of fatigue, and then one eye drifts away without the other. So they're losing what we call binocular fusion in that position. That can influence some to see double, or they'll develop visual suppression as a result of that. On the right there in the upper part, you're seeing our video head impulse graphs, our video head impulse testing graphs. The one in red, their head is moving to the right, which is graphed out in red, and their eyes are moving to the left. Originally, we thought they were having we thought initially off the first test, hey, they might be having their vestibular ocular reflex might be dysfunctional. That might be a frank pathology in the vestibular system. But on closer examination and looking at the video is that they actually moved symmetrically. They just couldn't hold their eyes there. So when you're seeing all that breakdown on the side there, that's the loss of binocular fusion and the drift away and the difficulty holding in left eye movement, which is right head impulse. And then left impulse, not the perfect test, but you can see it's largely symmetrical. In the bottom part on the right side, you're seeing our smooth pursuit graph where they're tracking, but you can see at the end ranges, the red and the blue are splitting, which is the left and right eye are splitting. They're losing it, the binocular fusion in that position. horizontal prosaccades as compared to random saccades, which we talked about earlier, the gap versus overlap. Overlap or prosaccades were above normal limits for his age and gender in terms of the latency. So he was slow to react. His latency in antisaccades was also above normal limits. His directional error rate was above his age and gender norms, and his anti-cost, which is the difference between latency difference between pro and anti, seemed to be outside range, especially for an athlete. His decision making was slow. In VOR cancellation or gaze stabilization, which they are asked to keep their eyes on a target, and we just slowly move their head and at a very low velocity and see if they can maintain eye position, is that it was still, the eyes were smooth, but there was end gaze nystagmus present at both directions, even by just moving their head and not their eyes. Convergence and divergence were dyskinetic, although there were normal pupillary responses to accommodation, but the right eye was fatiguing quickly and drifting away. They weren't syncing together, left eye and right eye. And as I mentioned, some of the VHIT findings from before is just that in the right horizontal head turn, there's a post head turn of saccade, not because of a vestibular issue, but very likely because of a loss of fusion and a loss of fatigue in that eye position. We ran some other studies that are interesting to look at. He was reduced in cervical range of motion in the movements noted there. So flexion, extension, and left cervical rotation was limited. His subjective visual vertical, which is the visual perception of the line of gravity, was outside of normal range, as was his head tilt. His dynamic subjective visual vertical was not great either, but we don't have great norms for that. And interesting enough and important for an athlete is that his dynamic visual acuity was 7.5 lines lost. So he went from a 17.5 at static to 10, and that's a really big reduction in right rotation specifically. There's a few others that are outside of range, but that right rotation, which we saw earlier in our VHIT test, was dysfunctional. He was, I don't want to use this is a literal world, but metaphorically, he was blind when he's turning his head, which as an athlete, again, we're not moving or playing in a certain static head position. Head movement matters, right? So when we're looking at eye movements, tying that in, we also want to look at head movements and neck as a function of those head movements, and then also layer in the vestibular system on top of that, and understand the neural networks behind those. So as we can see here, the graphical representation of that loss in those. And so you can see 17.5 was his static assessment of visual acuity, and then dynamic visual acuity in head motion at speed, which is hundreds of degrees a second, is that he couldn't maintain or see anything. He couldn't make out what the target, or there's no acuity. You couldn't tell us what letter was being flashed, or some people use a symbol, those kinds of things. And you can see there's a larger than normal loss for an athlete like that. And so we're able to relay that information to his team and say, hey, it's not the best idea. We're not approving a return to play for this athlete. He's at a high risk for re-injury. We think he's already still injured, and we think he should hold out for longer. And that was valuable information for the athlete himself. This athlete had an agent and a family that cares about him, and they also had a team that cares about his well-being moving forward. So we were able to coordinate with the whole team. Even though they had done their examinations, but with in-depth testing that we have at our disposal here, was able to give us a deeper kind of lens into this patient and get an idea. And also, on my side of things, helps us direct rehab and things that we're saying, these should be at a certain level before we can expect you to return to play. So just an idea of how this patient and another patient, how we can put that whole picture together and then take that into the rehabilitation and use it as a barometer of progress of when they should be returning to play and all those kinds of things as well. So thank you very much, and I'll lead it back because I think we're going to enter the question period, and happy to sit and just discuss anything that you guys would like to.